Afternoon, everybody, and a warm welcome to our speaker, Dr. Ashish Kakar. I thank you, sir, for sharing your insights on pandemic. It's the need of the day and need of the hour. I'll also like to welcome Dr. Ratika Rai, Principal Thai Mukambika Dental College, Chennai, and I welcome the faculty members of Thai Mukambika. So before we hand over to Dr. Ashish, I'd like to welcome Dr. Ashish Kakar. Dr. Ashish Kakad actually needs no introduction. He's a institution on its own, but we had to go by the protocol. So Dr. Ashish Kakad is a graduate from Maulana Azad Dental College and Hospital. He attained his master's postgraduate from Eastman Dental Hospital, London, in prosthetic dentistry and graduate certificate specialty in prosthodontics from New Jersey Dental School, USA. He has been in private practice in India for over 25 years with special emphasis on cosmetic dentistry, dental implantology, and prosthodontics. He is a senior consultant at Indraprastha Apollo Hospital, New Delhi. He has several international presentations, including papers at IARDRW, COI, ICOI section, and ICOI World Congress. He is the founder, president of, and founder member of the Academy of Oral Implantology, New Delhi. He is also adjunct assistant professor at Rutgers School of Dental Medicine, New York, USA. He has been in active involvement in clinical research on dental devices and dental implants and biomaterials. He's clinical mentor for Nobel Biocure Implant Training and a faculty of DGOI implant course. He is also fellow and diplomat of the ICOI and honorary member of BADI, fellow of the ITI. He has been extensively published internationally and is the author of the textbook Oral Implantology. Apart from that, he is fellow and diplomat of Academy of Oral Implantology and is associated with a lot of research projects. I welcome you, Dr. Ashish Kakar.
So, and I think we do have a reasonable number of audience present today. So, we all are facing a major challenge right now in not only in the profession but also worldwide of COVID-19, the pandemic, which is really horrifying all of us, both in our personal lives and our professional lives. So how we can overcome this, what is the impact on our practices, on our lives, and what do we do when things start to come back to normal, and how do we manage the situation? So let's talk a little bit about the global pandemic right now. These are figures from this afternoon. That's almost 28 lakh people worldwide. You can see the graph. And in total, the deaths are close to about 2 lakh people, which is increasing quite rapidly. And as the pandemic moved away from the east to the west, we saw very, very horrifying numbers all over the Central Europe and Western Europe, and now spreading more towards North America. So what is COVID-19? It's a pandemic. It's a viral infection. How do we define a pandemic? Pandemic is defined as an outbreak of a disease that occurs over a wide geographic area and affects exceptionally high proportion of population of people worldwide. So we also know that it's called SARS-CoV-2 2019. It's called novel coronavirus COVID-19, which is now becoming more popular terminology, or NCO. So we know that the initial outbreak was in China, in Wuhan, way back in December. That's at least when they reported it to the rest of the world. We do have a reason to believe that it was there much before it was reported. And it was reported to the WHO on the 31st of December 2019, hence the name COVID-19. And since then, it has been playing havoc worldwide. What are the symptoms of this flu. I mean, it's an influenza virus, it's a flu. So we will have very, very common symptoms like fever, which could be above 100.4 or greater, dry cough with shortness of breath and difficulty in breathing. And over a period of time, you will see that the oxygen saturation levels keep going down in these patients, especially if they go into advanced stages of the disease. Less common symptoms may include diarrhea, acute aches and pains in the body, running nose, and general feeling of lethargy and weakness. And the protective measures as defined by the Centers for Disease Control is to see that we are washing our hands frequently. We are making sure that we are maintaining good social and physical distancing. Avoid touching our face, our nose, our mouth, our eyes, and also practice good respiratory hygiene, because this is now becoming, there is new modes of transmission which are being identified. And we will discuss that as we go on. And if you have primary symptoms like any of the fever or lethargy or dry cough, we should see the medical attention immediately. Fundamental principles of good hygiene as advocated by the CDC, the Centers of Disease Control, the WHO, and other guideline authorities like ICMR, they should be followed. And this morning I took a course in hand hygiene techniques, and it was quite a challenging course itself from WHO, and it's available online. It's a short course, but they give you different clinical scenarios as to how you would approach a certain patient, and when you would wash your hands and how you would wash your hands or sanitize your hands. It's very important for us as healthcare workers to realize that. So I would strongly recommend that all of you do take this course. It's a very short course, but really informative. And there are certain things that we all miss from time to time. So it's a good refresher. And what better to do than to get certified by WHO on these techniques, because it's important. The effective hand washing is very, very important. So we have to look at our profession, which is the goal. Our profession is actually the bottom line for this presentation. We need to gauge and take a deep dive into our profession and see what all we can do to safeguard our patient, the doctor, the staff, and indirectly our families as well, because when we are treating or seeing these patients, we can potentially bring this disease home. So dentistry has always been in the forefront when it comes to laying down protocols and challenging situations. We've already fought a lot with situations including handling blood-borne diseases or body fluid-borne diseases like hepatitis and HIV. And I think we are now in a situation where we should be able to come out of this and come out with a certain protocol so that we are all protected for the future. This is not the end of the profession, please. So, let's not worry about it too much. Having said that, it is going to take some time. It is going to take a few months, few weeks before we start getting some positive protocols. But as of now, there is guidelines which are available for our profession, and we will go over that as we move on in the presentation. If you look at the Centers for Disease Control, this is what we are practicing right now, the social distancing, putting a space between yourself and others. And the recommendation is about 6 feet of space or 2 meters, which is now considered as a personal space. I would call this more as a physical distancing than social distancing, because socially we are all connected. Like right now, we are connected on webinars, we are connected on WhatsApp, Facebook, all kinds of social media do connect us. in a very nice way. And physical distancing would be the right terminology for this kind of setting. So how are people affected by this spread? It is spread from person to person through small droplets from the nose, the mouth, where the person has the virus already, by coughing, sneezing, exhaling, touching something, and we will go over all the surface decontamination and the surface survival of this virus in the future slides as we go on. Currently, the estimated incubation period is between 1 and 14 days, but within 5 to 6 days, you do start seeing major symptoms for most of our patients. So the incubation period is very important to understand that from the exposure, because the testing would depend on the incubation period, and there is different kinds of testings which are available. We will enlist them and go over them in detail as we go on. Patients who are older, patients who are with pre-existing medical conditions like diabetes, renal disease, already patients who have COPD, and patients with cancer, all patients who are immunocompromised do definitely fall into a high-risk category and can go into advanced stages of this disease. So they need to be very careful. So we have to protect our elders at home and make sure that we are keeping this virus away. So what is a close contact? So 6 feet or 2 meters according to the Centers of Disease Control. So, this has a direct impact on your practices. And we have to make sure that when we are bringing our patients in, the waiting rooms should be distant for at least 2 meters between the two patients. If you are bringing in two patients at the same time. You have to make sure that unprotected direct contact with the infectious secretions or the excretions of the patients have to be avoided. We've also now heard of reports where the virus has been found in the exhaust fans of the toilets that the patients have been using, which means that when you're flushing the toilet, we have to make sure that the lid is actually closed. It's very important to take that precaution, because the aerosol effect is there even in your flushing system. So, these are things which are coming up every day. New information, new news is coming up. The mode of spread is a little more complicated than what we actually think it is. Let's have a look at this video, and this is something that has come to me just more recently.
Experts are now looking at this new infection mechanism as the key to preventing the further spread of the virus.
ただの会話の中で感染が広がっているとか、ある程度の距離があってもそれが広がっているような、そういった事例を見ると、通常の飛沫感染だけでは説明できない。非常に小さな粒子ということで、マイクロメーターの粒子、マイクロ飛沫感染というのを読めるような、そういった状況が起きたんじゃないかなというふうに考えられます。
So how does this take place? NHK is conducting an experiment with a group of researchers. The team will track particles in the air using laser beams and a high-sensitivity camera. This technology allows us to detect droplets as small as 0.1 micrometers wide. The experiment starts. First, sneezing.
Just look at that, the projectile.
We can see a large
sneeze.
droplet about 1 millimeter in diameter. It quickly falls. But let's look through the high sensitivity camera. We can see small particles that seem to glitter floating through the air. These particles are all smaller than 10 micrometers, or 1/100th of a millimeter in diameter. Let's take a look from a different angle. They're small and light. You can see them drifting through the air. These are microdroplets. We're learning that sneezing isn't the only source of these droplets. We ran the same experiment on a close-range conversation. People generate a lot of microdroplets when they talk loudly. The droplets between these two stay where they are. They don't drift away. It's not yet known what volume of microdroplets leads to infection. But Tateda says we can't rule out the possibility that microdroplets have spread the virus to some extent.
そのマイクロ飛沫、小さな粒子の中にもたくさんのですね、生きたウイルスがいて、大きな声での会話、あるいは激しい息遣い、そういった中でですね、このマイクロ飛沫ができて、それが近くの人、その人が吸い込むことによって感染が広がる、そういったリスクが見えてきたものと思います。
The risk of infection through microdroplets becomes even greater in a closed space with poor ventilation. This lab is simulating the movement of microdroplets in an airtight room.
So see the extent of the droplets which is going from a distance,
About
especially
10
if you have
people
a
in an enclosed
crowded
space
room
the size of a
like this one.
classroom.
This can actually get into a very cascading kind of a
coughs once.
situation. Look at the
And
time lapse
spreads about
in
100,000
the bottom of the
droplets.
screen.
Large droplets are shown in blue and green. Most of these fall to the ground within 1 minute.
So 1 minute is a very long time for a droplet.
But the
to remain.
microdroplets, shown in red, continue to drift. This simulation uses only microdroplets. 5 minutes later. 10 minutes later. 20 minutes later. The microdroplets are still floating in place.
空気がよどんでいると、つまり空気の流れがないということで、マイクロ飛沫そのものは、落ちたり、違う場所に動くことはできませんので、正直。
So as we saw, this is how the droplets are spreading, and we never knew about all this research till we saw all these Japanese high-end cameras showing us that the droplets can travel to a certain distance even in a small hall, and patients potentially can get infected, and the droplets do remain up to about a minute. So this is really important to understand that we have to practice good hygiene and good, maybe if I can call coughing or sneezing manners, if we can put it that way. So the idea over here is, how do I keep my dental office safe? We have to clean and disinfect each and every surface, like doorknobs, light switches, cabinet handles, the front desk area. And we have to get rid of all our magazines, all the periodicals, the journals, the wall hangings, extra furniture. I would even remove the table from from the office, the waiting area. Make sure that the patients don't lean over your reception, and there is a good distance which is maintained in order for them to speak with your staff or the receptionist. And most important thing is to offer them sanitizer at the front desk and offer them a mask as they come in, so that they don't infect or potentially don't get infected themselves. So I will talk about masks in a minute. And also important to understand and screen these patients over the phone before the appointment to check out their travel history, to check out their symptoms, to check out, who they have met, and all kinds of things can be done beforehand. And try and fill up all the forms online, because the moment you hand them a pen and paper, the virus can stay alive on cardboard and plastic, as we will discuss. And follow the CDC infection control recommendation. We have to make sure that we are maintaining social distance, physical distance, wearing our PPEs, and also protecting the dental labs, because if we are making impressions, we have to disinfect those and send them over to the lab. I would strongly encourage to do more digital dentistry if possible. But having said that, it could be cost prohibitive for a lot of people at this moment in time. But it is important that if you do have access to these gadgets, it's always beneficial. To minimize the chances of exposure, instruct all our patients to reschedule our appointments for now, adhere to standard transmission-based precautions like we always do, wearing our PPEs. And one important thing is to avoid, at this moment in time, only do all emergency procedures and avoid performing any aerosol generating procedures, which actually have, at least in our country, we have had a Supreme Court ruling in the recent few weeks to have a control on these aerosol generating procedures. One more thing is important to use, instead of your normal masks, we would now be using as a standard of care N95 respirators, because these have more filtration power, and we will go over the difference between the respirator and a mask as we go on in the presentation. There is also a recommendation to protect your N95 mask by wearing a regular surgical mask over it, so that you can avoid any spills and splatters and get away from getting the mask very moist. So what is the difference between a mask and a respirator? We've all been using surgical masks for several, as long as we've been practicing. Surgical mask is intended to protect the mucous membranes of the wearer from contact with patient's body fluids. So it is basically to protect the patient from who has respiratory illness and reduce the droplets released by that patient in the air when they cough and sneeze, as we saw in the video. If any of these subjects were wearing a mask, then the transmission would be much less. Whereas a N95, a medical N95 respirator, which is made popular by 3M, is actually filters the air particles which are reaching the respiratory tract. So the different N95 respirators have been used for different purpose, and OSHA, CDC, FDA, all of them agree that the healthcare workers treating active COVID patients, or we should assume that every patient is an active COVID patient, should use N95 respirators for their protection. So N95 will remove about 95% of 0.3 micron particles, and there is an optional valve which reduces breathing resistance during exhalation. And material is very tough yet flexible. It is a non-woven polypropylene fiber, which is the same fabric which is used for our PPEs. If you look at the edges of the mask over here, these are just swaged, and the mask has to be really fitted very well so that there is no gaps between the face and the edges of the mask. And we will go over a video as to how to wear this mask properly, because if you're not having a proper fit of the mask, you are actually adjusting the mask more, especially during the procedure, then there is more chance of an infection spreading from the patient's aerosol or patient's mouth to your face, and it could do you more harm. And another word of caution, that these masks are not very breathing friendly, so you need to really get used to them prior to starting your clinical practice. This is an interesting thing that I found from one of my groups, a COVID group that I'm a part of. So if you have a carrier who's not using a mask and a healthy person who has a normal surgical mask, there is a 70% probability of transmission of infection. Whereas if the carrier is wearing a mask and the healthy contact is without a mask, there is only a 5% chance of getting this infection into the other person's respiratory tract. So mask is more important for the patient. Mask is more important for the carrier in general population. But for healthcare workers, we have to make sure that we are wearing the mask. And if both the subject and the carrier are wearing a mask, then the probability is also very, very low. It goes down to about less than 2%. So this is a video showing...
Protect yourself and your loved ones. Here are the 6 steps to wearing the N95 mask. Step 1. Wash your hands before putting on the mask. Step 2. Select an N95 mask that fits you well. It's available in different sizes and models. Step 3. Hold the mask in your hand and place it firmly over your nose, mouth, and chin. Step 4. First, stretch and position bottom band under your ears. Then, stretch and position top band high at the back of your head. Step 5. Press the thin metal wire along the upper edge gently against the bridge of your nose so that the mask fits nicely on your face. Step 6. Perform a fit check by breathing in and out. While breathing out, check for air leakage around your face.
So this is very important to understand that your mask has to be fitting very, very snugly. And if you compare the left side of the image, which is the 3M N95 mask, to the right side of the image, you can see that the swaging over here can become potential for opening. So we have to be very careful how we adapt the mask. The interesting thing to see is the N100 mask, which has got respirators. It's got a silicone fit, and it's a very, very snug fit on the face. You can change these 2091 N100 respirators on a daily basis, and you have a very snugly fitting mask over here. So the preference right now is to get a N100, which is also very expensive mask, but it's presently not available. So in due course of time, I think this would be the mask to wear, the respirator to wear for our healthcare situation, since we are dealing with lots of aerosols. Internally, what I have been doing, we have printed a few N95 mask frames in our own dental clinic. We have the NextDent 3D printer, and this is project has been done by my daughter and my son. My daughter, she's in the 3rd year of dental school, and my son, who's like 12 years old, he's very fond of doing all these experiments. So we have been able to print these masks. However, this is the prototype over here showing, and this is the mask. So you can put a respirator over here, sandwich this part, and this is the frame that goes on. And it's available in 3 different sizes for different facial fits. And we also got some press coverage for this in the recent past because we have to protect and try and get longevity out of the mask, because these are now being sold at a very high premium pricing. So the ADA recommendation at this moment in time is to say that the nationwide, we should have only emergency procedures to be done. They want the dentist to postpone all elective procedures for next few weeks and concentrating only on dental emergency. We have to be uh, very particular that it is our obligation to treat each and every patient who've been loyal to us in the last so many years. We cannot abandon our patients during these difficult times because patients do have emergencies, patients do require treatment. So all emergency procedures should be carried out and patients should be given relief. And we have to make sure that every visit to the dental office is a safe visit. And we should cover all sanitization uh, rules as we will discuss, all disinfection, autoclaving, so that it becomes a safe place for both us, our patients, and our colleagues and our family, as I discussed earlier. So this is a list of the emergency procedures given by the American Dental Association, and actually has very few things which are covered. And these are the things that they are recommending if you have severe pulpal inflammation, pericoronitis, surgical, dressing, dry sockets, if you have osteitis or dry socket, abscess, which is causing pain and swelling, you have a tooth fracture, or a dental trauma, or if a temporary situation or temporary restoration which has come out, which is causing pain and discomfort or swelling and irritation to the patients. These are things that we need to look into. We must make sure that we attend to our patients and give them relief. And similar healthcare guidelines have been laid out by CDC and the Canadian Dental Association for our profession. So what happens to the coronavirus if someone sneezes? Obviously, it's a lipophilic virus, it's a fat coated virus, so it's not a light virus. That's the good thing. It tends to fall down after a certain distance, depend on how projectile the sneeze or the cough is for the patient and how many droplets are coming out, as we saw in the experiment earlier. So we need to make sure that all the surfaces which are there in our dental offices are clean, because we are dealing with aerosols as well. So, we are aware that, the virus will thrive in oral mucosa, in nasal secretions. And unfortunately or fortunately, that is the area that we are working in. So we are right in the lion's den, if I may call it that way, because the virus is right there. And we should assume that each and every patient who's coming to our practice from this point onwards is either a carrier or a positive patient. And this is the only way to deal with our patients in the near future, at least till the time that we get the vaccine out commercially, which is under progress. So it is stable for several hours and days in aerosols and on surfaces. This is from New England Journal of Medicine from March. So it is detectable in aerosols for up to 3 hours. It is detectable on cardboard up to 24 hours. We saw what happened in South Delhi 1 week ago. There were 68 families who were kept under the scanner because the person delivering the pizza in the cardboard box was tested positive. So that's what we need to understand, and that's what we need to be sure about. Let's look at the plastic surfaces, the stainless steel. Up to 2 to 3 days, the virus is viable on these surfaces. So that's what we are dealing with. We have instruments, we have tabletops, we have and all kinds of surfaces where this virus can go and settle down. The good thing is that it's a lipogenic virus, so there is a fat layer which can easily be disintegrated. And the good news is that it can be deactivated by very simple means. However, we need to follow strict hygiene and strict disinfection for our patients and our office as well. So it will stay on aerosols for hours. What is an aerosol? particles less than 5 microns, not 50 microns in diameter, which can be in saliva or nasopharyngeal secretions. It may also include plaque, blood, tooth material, viruses, and bacteria, and they can remain airborne depending on what kind of drilling protocols you are using and what kind of drills you are using. We will go over that also very briefly. How does that aerosol differ from a splatter? A splatter is anything which is more than 50 microns in diameter. It behaves like in a droplet manner, and it will shoot out like a bullet and fall on the floor. So that's the good news, because it is heavy, so it will fall very quickly. And also it can evaporate and become re-airborne as dust. So it's important to make sure that there is no dust particles in your office also. So the aerosol generating procedure, the worst procedure is the sonic and ultrasonic scaling that we use, the air-water syringe, and obviously the high-speed handpiece. So these produce a lot of aerosols. People are now trying to advocate electric motors with irrigation. Obviously, these will generate less, or even lasers. If you're using hard tissue lasers, it will be less. So there is still people studying the effects, and I think we will get some new information in the next coming few weeks regarding this. So what is the assumption that we should be working with? The assumption is, if a surface can be contaminated, assume it is contaminated. So every surface that you are working around, your dental chair, your hand pieces, your suction tubings, your countertops, your tap handles, doorknobs, everything has to be looked into with an eye of suspicion. I mean, years ago, I attended a small seminar called "If Saliva Were Red," where they were trying to see and show where all your hands are touching, and then you touch other surfaces. Just because saliva is not visible to the naked eye, as it's clear, what if there was blood instead of that? We would react very differently. So this is the exact same scenario we have to address and assume that we have to decontaminate all our surfaces. The most common decontamination is done, or to disinfect, is sodium hypochlorite. It has been used, time tested, been used in hospitals, medical labs, doctors' clinics, nursing homes, burns unit, all kinds of places, dressing rooms. And it is shown that it is very, very effective. Now, sodium hypochlorite can be found in the bleach. We all are aware that the bleach for clothing like Ala or Clorox, these do have sodium hypochlorite in them. And 1% sodium hypochlorite would actually be very, very effective. What does 1% mean? In a 1 liter bottle, 1 ml. So that's the amount that you need to use, and it remains stable for at least 2 to 3 days. A stock solution can be made, and after each patient, all the areas should be disinfected either with a spray. Floors can be mopped with this. It is very, very safe to use, but it's also very corrosive. We need to understand we cannot use it as a fumigation on our dental equipment. If you use it, it is actually going to kill the bacteria and the viruses, but it will also kill your dental equipment. There has been reports of short circuiting in several offices. There's been reports of equipment, the PCB boards for X-rays, for dental units going bad because it's highly corrosive, and it actually would go into areas where you don't expect it to go into, the circuits of our machinery. So, and it's also a skin and eye irritant. What is the alternative? The hypochlorous acid is now proven to be the clean alternative to sodium hypochlorite. And if you look at the internet, there is plenty of data out there which shows that it is as effective as sodium hypochlorite. Now, 2 or 3 advantages of hypochlorous acid. It has got a near neutral pH. It is almost around between 5.5 and 7, depending on how you manufacture it. It can be used real time to fumigate your dental operatory as you are working. It is safe on skin. If you look at most of the eye drops, which are used as lubricant, hypochlorous acid is used in all of them, just for eye cleaning. It also is being used in the food and poultry industry. If you see, to disinfect the vegetables, to disinfect the poultry, and it is very, very effective against the viruses, and it has shown to be very, very clean. How is the hypochlorous acid working? I'm a part of this COVID-19 discussion, dental discussion group, and it's just growing every day. This is the message that I received on Wednesday. So it says that micromisting and atomizing unit to sterilize or disinfect our surgery with 10 micron fog with 300 ppm of HOCl for only 5 minutes can achieve 99.999% sterilization and a quick and effective protocol, safe protocol. So people will ask, where do I get the hypochlorous acid from? It's very simple. I just did an experiment yesterday over here. I just made about 1.5 liters of hypochlorous acid at home. Right where I'm sitting, just put it in a jug, and it is basically a salt solution with some vinegar, and you can run some electricity through it to generate the hypochlorous acid, and you can test the pH of this. So there is a specific protocol. I can discuss that with you, or I can send that to you, and it's also available on YouTube. So you basically are ionizing this saline solution and creating hypochlorous acid so that you have a good disinfection. Disinfection of water lines is also important. That can be achieved with 0.01% of sodium hypochlorite. So 0.01% and not 1% that you use for the floor. So you need to dilute it about 100 times more. I looked at how hypochlorous acid can be procured. It is being used for swimming pools. And I saw on India Mart that you can get 40 kilograms package for swimming pools or for, for your retail vegetable vendors or poultry vendors. And it's only 11 rupees a kilogram, and a kilogram will last you a lifetime. So it's not an expensive way, but it's very, very effective. So I would recommend using hypochlorous acid to fumigate instead of using sodium hypochlorite. And it's also very, odor-free, and it's not a skin and an eye irritant. So that's the other advantage. So what are the precautions we need to follow in the clinic? We need to follow certain scheduling techniques for making sure that you're maintaining physical and social distancing for our patients. First is to minimize time in our waiting areas. So we should only have one patient come in at a certain slot. Only the patient who is to be treated should be coming to your waiting room or your clinic. He should be wearing shoe covers, a mask, and if required, unless the patient is a minor, we should not allow an attendant to come in, even in the waiting area, because patients have this habit of walking into your operatory and can my cousin come, can my sister come and sit over here? That should all be discouraged because of infection control. If we have more number of patients, because people are very popular and people are wanting to see you, then we should ask them to wait outside in their cars. That's the safest place for them to sit. And then your office can send them a text message or call them and ask them to come in. Footwear should be removed, and then shoe cover should be worn. It's better that you give them, just like in a temple, you can remove your shoes in your car, and then they can come in with a shoe cover, or a second shoe cover can be worn, because this is the time to avoid any sort of contaminant coming into your floors as well. 6 feet of minimum distance, as I said, 2 meters. A complete medical history should be taken. And then fever should be measured. However, having said that, fever is very subjective. We have to understand a lot of our patients come into the category of elder patients who are taking NSAIDs for joint aches or whatever, and that also has an antipyretic effect. So making sure that you have a complete medical history and don't rely only on fever. If we had followed the fever protocol, all the airports were screening these patients since January. So why did the disease spread then? Because fever is not really the benchmark yet. It is an important tool to have to measure non-contact thermometers and measure the temperatures, and then making sure that these are recorded in the patient's file, so that tomorrow if there is a litigation of any sort, you do have everything documented. This is my dental clinic, the waiting area and the reception in the bottom right hand screen. How would I modify this, or how I have modified this is the following. I would probably have one patient sit in each of the corners where the star is, and one patient over here, so that I have at least 6 feet of distance between these three patients. I would also try and get rid of my beautiful panoramic picture over here, all the props, the decoration materials. I would remove this whole table, the magazine, everything, so that I have a plain vanilla office with just seating. Or I would even remove these 3 sofas and put 3 chairs in 3 corners over here, and then mark them at a 6 feet distance of each other. Please understand, your dental clinics will be judged by your patients, not by how beautiful or how nice or how aesthetic they are. In the near future, they're going to be judged by the patients as to how infection control compliant they are. So the safety is the most important fact right now. And to retrofit everything into a present dental scenario or a present dental clinic is a very challenging task, but we will have to take some very strict measures. What I would also do is to block all the public areas. I would block the toilets. I would block, if you have lifts and elevators, we have to block those, and keep the doors ajar, like keep them open so that patients are not touching the handles, and also to keep a good circulation of air. Doors and windows need to be open. Presently, what I have heard is even in the Army Dental Clinic, they are not using air conditioning, which is a big no-no unless you have HEPA filters. So it is important to have good ventilation and not have air conditioners functioning. And more on that as we go on, because things are going to get tougher as we go on in the next few slides. So this is my waiting area. I would keep a 6 feet distance, maybe put a tape over here. All the payments that will be done in the near future, at least in my office, will be all electronic. If they want to pay by credit card, I would have a contactless credit card machine, or I would encourage prepayments with bank transfers or Google Pay or Paytm and other things like that. So the zone of my aerosol would be all over here. I would probably get rid of all this equipment unless it is absolutely required, and have minimal number of tabletops and things which can potentially get infected. the good news is that Henry Schein and other companies are now announcing the availability of COVID-19 point of care rapid testing facilities on machines and kits. So as of March, maybe in this month, they announced it in March. So in this month, it will be available for all of us. And I think the testing should be done for all our patients and our staff. You know, if you want to do serious dentistry, it should be done on a daily basis. This is at least what I feel till the vaccine comes out. Again, it's going to be cost prohibitive for a lot of us, but we have to safeguard everybody. And one bad case or a one case of transmission from a dental office to a patient or the other way around can actually ruin your practice for the the reputation that you build up can go away because of small infection control situation. So let's see what kind of testing is available for COVID and what are the different types of tests. We do hear that we get false negative tests for a lot of people, and there is a reason for that. So let's look at the testing which is available.
Hello, I'm Dr. Michael Kakar from Rochester, New York, where I'm a specialist in respiratory infections. Testing is important because we're trying to triage cases.
It's very important to understand who is ill and who is not. If we don't have access to proper testing, the truth is we don't know how to properly treat, diagnose, or screen the patients that we're dealing with at the front line. It creates a lot of anxiety, concern, and uncertainty about where things are going and how we're going to be able to treat them to make them get better.
There are three types of tests: the PCR test, the antigen test, and the blood test or serology test. The PCR test, that's where you take a nasal swab deep into the nose or the throat, and then you process looking for a molecular evidence. PCR test is best before you even have symptoms. You can detect the virus with PCR, and it's still there and easily detectable in the first week to 10 days of an illness. That's test number one. Antigen test, also nose swab or throat. There you're looking for the coding of the virus as being detected by a laboratory test. By 2 weeks into the illness, the PCR test is going down. The antigen test is really not reliable until you start to have symptoms. And by the third or fourth or fifth day, as the symptoms are going up, that's when the antigen test really works best. And the third test, serology test or blood test, this is looking for immunity to the virus. It takes about 10 days for your body to make the first response of immunity that we can detect in your blood. And that's called the IgM test. And then about 2 weeks or 3 weeks later, we can detect it even better with another serology test called IgG. IgM is the first antibody response. We normally can detect that somewhere between 10 and 14 days after the onset of an infection. So the next window of time we look at is maybe around day 21 to day 30. Now the IgG is much higher than the IgM. At that point, you probably won't detect any IgM, but you'll see a sky-high IgG level that tells you, okay, the maximum immunity response has now been measured.
Generally, when you build up an antibody resistance, it means that you are protected from getting the worst case scenario of that illness again.
For the PCR test, doctors cannot do that in their office. It has to go to a hospital or to a laboratory. Whereas the antigen test and the serology test, those tests may be possible in a doctor's office or in an emergency room or urgent care setting. However, be careful. As these tests become available, you want to have something that is FDA approved or has been approved under an Emergency Authorization Act or some type of a waiver.
The most important thing for us is accurate, reliable, and factual data.
So we are in a challenging situation. Private practices and institutions are up against a very, very stiff challenge. And this is a warning which is just come out from the British Dental Association, it's not going to be easy days looking ahead, especially in institutions, because it would be very difficult to maintain this kind of distance. Having, keeping in mind that we also need to have the DCI regulations for the number of equipments which are functional. So, these are going to be very, very challenging times for our profession. So let's look at the risk assessment for our patients who are walking in. So there is a green zone, an amber zone, and a red zone over here. So does the patient know the COVID-19 status? Are they IgG immune? We already saw what IgG immune means. We saw the testing, so if there is an immunity, then they are safe. If they are not immune, we have to assume that all these patients now fall under a very high risk category. Okay, so, or if they have had contacts or they are symptomatic, we have to use the PPEs for all these patients. So if you look at these three variables, there's going to be a very small population who would have an IgG immunity at this moment in time. But we would have more and more people fall under this umbrella, and the outcomes are very high risk. So we need to take care of our PPEs. Currently, we are aware that there is a worldwide shortage of face masks. The CDC recommends the reuse of the N95 face mask and the respirators. Again, as I said, these can be protected with the use of an additional barrier like a normal surgical mask. It's important to protect that because we can reuse them up to 3 or 4 days. Also, barriers like face shields can be worn on top of that so that they will protect us from splashes and splatters of our different fluids that we are working with. And a good fitting of the face mask is of utmost importance. Also need to understand that the moist and the wet face mask should be immediately discarded. They are of no value at all. As I said, every visit to a dental office should be a safe visit for our patients. Patients are very scared. I mean, if the lockdown opens on the 3rd of May, don't expect a patient to come to you on the 4th of May because they would like to avoid any elective procedures at this moment in time, the time of uncertainty. Same holds true for patients, for people. I don't expect anybody to start going to movie theaters or to malls or to clubs or restaurants. I mean, there's obviously some crazy people out there, but in general, I would not expect all these public places to be frequented by people. So, I mean, a dental clinic would be probably their last priority. So we need to kind of bring the confidence and the safety levels back for our patients so that slowly everything comes to a normal. So I was looking at the Ultraviolet Association, the International Ultraviolet Association. So they have had some very interesting work which has been done on the 2 coronaviruses, which are the predecessors of the SARS-CoV-2 or the novel coronavirus. So if you look at SARS-CoV-1 and MERS-CoV, which is the Middle Eastern respiratory disease, and the South Asian respiratory disease, which were there earlier, the UV light in a spectrum of about 260 nanometers has shown to inactivate both of these coronaviruses. So an important caveat is that the inactivation has been demonstrated under very controlled conditions in the laboratory. So there is no harm having these UV lights as adjunct to our PPEs, to our surface disinfection, to our high evacuation suctions, the HEPA filters. So these are not very expensive and they can be used for disinfection in between patients. So that's very important to understand that. So we have to combine other technologies in a multi-barrier approach to make sure that the pathogen is not killed by one method, then it's definitely killed by another. So UV chamber inactivation would probably be a very, very important adjunct to have in our dental laboratories. So, and these are available very, very easily. Now, certain practices did open. This is from Poland. I mean, I picked it up from a group where this gentleman has now put a tent for screening outside his dental clinic, and patients are disinfected over here. And then there's clear barrier lines where patients can go, where they can park. All the essentials are present as you enter the dental practice: contactless thermometers, face mask, hand sanitizers, and sodium hypochlorite. Areas where patient can go and not go. They are not supposed to be touching any of the railings and or the switches. This looks like more like a war zone where the reception is completely isolated. A 6 feet or a 2 meter box is prepared so that, you know, patient can talk and make future appointments. And N95 respirators, one entry for the clinic and other for the exit. And it's all been protected with very heavy duty plastic so that the aerosols do not go out into the public areas. Is that what the future is going to be? I'm not really sure, but this is what I've been able to see in different countries. This is what people are practicing. And this used to be their coffee room, which has now become their PPE changing room. They've gotten rid of the coffee machines. They've gotten rid of all the water dispensers, because these are the common areas where the public can stand and sit and start infecting that area. So, I mean, this is what we need to do: remove all kinds of extra paraphernalia for even your staff, because you don't want your staff to be hanging around in these areas too long. Public toilet access is closed. You need to inform your patients that we do not have lavatory facilities in our practices available for public use. So they need to make sure that, you know, they are relieving themselves before they come to the dental practice. And as I said, if you do have elevators and buttons and switches, they need to be completely disinfected or not made as public domain. Personal protective equipment should be worn. I mean, it has become the in word right now. Everybody who's doing anything is now doing personal protective equipment. So there is different varieties of personal protective equipment. There is a certain protection that it will offer. Not all personal protective equipment will work the same way. So you need to make sure that it is approved by the authorities, and the Textile Ministry has already set up an authority for personal protective equipment. It needs to be comfortable. It needs to be done in certain GSM. 90 GSM is the minimum. DuPont and 3M make very high-end personal protective equipments, but those again can be cost prohibitive. Do we change PPEs after each patient? Ideally, we should. Because the PPEs will get aerosol on them. Again, if you're not doing aerosol-related procedures, PPEs can be used for up to 3 to 4 hours for during the OPD timings. Everybody has their own version of PPEs. I don't know which is right or which is wrong, but having said that, the basic assumption is that all patients that you are treating are COVID positive or COVID carriers. So there is also a WHO course on how to put on and remove PPEs. I think this is another course that I would recommend. And these are short courses that, you know, will really help us to, gear ourselves to our practices as and when we go back to our practices, because a small mistake in removing or wearing the PPE is the difference between getting the infection from the PPE onto your body. So it's important to take these courses, and they are all free of charge. So it's important to understand the value of these courses. And I think all your staff should also be trained and certified. So once you have your certification, you can put it up on the wall. That will bring up patients' confidence as well. Again, there is various different gears which are available, different helmets, different face and nose protection area. Again, air purified respirators can be used, especially if you're getting into an area where the patients are infected. We have COVID positive patients. So these helmets have actually positive air pressure circulating in between. Obviously, the room needs to be also there with the air exchange if you're treating. And recommended air exchange is every 10 minutes. So the air from the operating room or the OPD or from the area where the patients are lying down or are sick patients has to be changed every 10 minutes. This is when you're dealing with infected patients. Another form of PPE where this doctor is now wearing a gas mask. I think it's not required. However, if you do have a good control on the droplets, I think our N95 or our N100 along with a surgical mask and a face shield would suffice for our purposes, at least till the time we get new protocols and established protocols coming into our practice. Again, this is achievable. These are simple plastic sheets which can be put to isolate areas. Again, 6 feet of marking can be done, and only assistant comes in when he's required to give you a certain equipment or a certain instrument. I have a feeling we would go to more and more hand instruments, more and more less aerosol generating drills, lasers, things like that, or are we just, at least in the near future, in the next few months, till we get a little more safe and we have a vaccine available. What about hydroxychloroquine? This is from ICMR, the guidelines for all healthcare workers should take hydroxychloroquine before they resume work. I would say they don't need to take it now because we're all quarantined, we are at home. So HCQ should be taken if you're planning to go back to work a week before that. A loading dose of 400 milligrams twice a day on day one, followed by 400 milligrams once a week for the next 7 weeks. So a total course of 8 weeks of medication needs to be taken for the healthcare workers. Again, it's important to understand that if you're G6PD deficient, this medicine can have some certain interactions. So you need to get that tested first. And obviously, this is not a very safe drug. So there is, cases reported of retinopathy, and also patients have had a nephrotoxicity shown with this drug. 2 weeks ago, I was introduced to this piece of equipment, which is high vacuum suction, which can be put chairside for aerosol inhibition. I really like the concept, but as I look at it more and more, I think this has got very little value for our practice as of now, because it is a highly inconvenient machine to use, and I'll go over that in a few minutes. So this machine actually sucks up all the aerosols and has a box unit which is open in your dental operatory. It goes through certain filters, and the fresh air is supposedly released back into your office. I don't really believe this would happen because all these filters have not been tested. This is a product from mainland China, and I have my reservations regarding the safety. I'm not having any reservation regarding the efficacy of the suction, But regarding the safety, if the same air is being recirculated back in my clinic, I could be breathing viruses as well. So I'm very skeptical about this. That's number one. Number two, it would be a highly inconvenient machine to use because it is covering your patient's face. I will go over the video in a second. And also, every time the patient needs to spit out, you need to move the handle away right over here. So this needs to be moved away, and then you're causing more of contamination on these surfaces. And also the cost factor is a little high. So I would stick to my conventional machines as of now, or I would reduce the number of aerosol generating procedures. You could always put a HEPA filter in your clinic. It's a high efficiency particulate air filter, which would remove at least 99% of dust, pollen, mold, bacteria, and any airborne particles up to the size of 3.3 microns. So these would be very good in addition to the air filters, the air purifiers that we are using in our homes in any case. But these again cost between 70 to 80,000 rupees for each of these filters, the machines. So these can again be quite an expensive investment. This is how the suction will work. If you can imagine how you would be able to see through this when you have a mist over here. Patient has to get up to spit out, or to rinse out. You have to move this arm. So I think this is highly inconvenient approach for the price that you're paying for this. Again, our Indian colleagues have been very, very innovative. So they've made these with the hollow pipes and a cellophane sheet, completely disposable. And then you can attach your high vacuum suction through these hollow pipes to clean up the aerosols. Again, vision would be very, very hampered. So, I mean, I'm not really sure how we would work when we have these gadgets around our patient. So that's, again, very, very difficult to understand. I think I've covered more or less everything from a clinical point of view. And I would like to acknowledge the following websites and the following sources for getting my information together: the ICMR, the Centers for Disease Control, American Dental Association, Henry Schein, International Ultraviolet Association, and OSHA for Dental. So these are the sources where I've got most of my information from to make this presentation. And also we have just come out with a publication last week in Dental Practice. This is an e-copy of the article, which is covering most of what we have done in our presentation today. And Dr. Manish does have a copy of this, and just feel free to circulate it in the profession. The more education we give to our colleagues, the more awareness we spread, the safer environment will be for all of us. With these words, I'd like to thank you for your attention, and we can have a session for questions and answers. I'll try my best.
Thank you so much, sir, for a wonderful presentation. It was really, except for the initial hiccups, that proves both the speaker and the topic are popular. So there was a house full immediately as we logged in. So maybe we can share the video later on. And I also welcome Dr. Ratika. We had to literally pull her in.
Yes, Dr. Ratika, I apologize that you were not able to join in.
Sorry, I just missed by a few minutes. And as he said, very popular webinar, I must say. It was